Alright, so let's talk about TPA only. Okay, TPA. She's not covered the way what I wanted her to cover. Okay, now what is TPA? TPA is tissue plasminogen activator. Okay, now what does TPA do? TPA actually causes thrombolysis and fibrinolysis. It actually busts the clot completely and thus opens up the artery. So the only FDA approved drug that you have is TPA to bust the clot. So TPA, the only indication that we have for a clot busting, only medicine that we have as of now in literature or for that matter presently US FDA approved is tissue plasminogen activator, also called as altiplase. Okay, now altiplase, how do you give altiplase in the first place? You give altiplase as 0.9 kg
10% initial over 1 minute.
So 10% over 1 minute and the rest over
60 minutes.
60 minutes. Okay, that's how you give TPA. Now TPA, and this is important, the method of preparation is very, very important. Method of preparation is do not shake the TPA, only swirl the TPA before you don't do all these things. Swirl, only swirl. Swirl, take the whole TPA, take it in a 50cc syringe and give it. Before that, you don't need to put central line, you don't need to put Ryle's tube, you don't need to put Foley's catheter, it's immaterial, don't do that. Because what will happen, sometimes you might think, let me do this urgently because other samajh lo baad mein dalna pade, so it will become difficult for me to put it. You don't think like this. Practically what happens is, at the time you're giving TPA, you start thinking central line, you start thinking Foley's catheter, you start thinking Ryle's tube. Nothing is going to happen. Ryle's tube does not prevent aspiration. Foley's catheter, you can hold on, the bladder is quite big, it can accommodate huge amount of urine, ultrasound, so you can figure out what is happening. Central line hardly is required in these patients, they don't get hypotension. Are you understanding? Even if they get hypotension, there is a NORAD that you can use peripherally. You are understanding? So there is no indication to put a central line, a Foley's catheter or a Ryle's tube before you start the patient on TPA. Clear? Before you start the patient on TPA. So TPA 0.9 milligram per kilogram is the dose, with 10% given as a bolus over a minute and the rest given over 1 hour. However, there is another drug called as tenecteplase. As of now, the evidence for tenecteplase is slowly getting more stronger. What is tenecteplase? Tenecteplase is a recombinant TPA. It is a recombinant TPA. It's nothing but the TPA, but it's a recombinant thing. The only difference being it's much more fibrin specific. It's much more fibrin specific as compared to TPA, number one. Second thing is, understand this, tenecteplase is given as a bolus. Okay, so it's immediate. It's acting much quicker. You understand? It's acting much quicker. So it does ring a bell in our brain that if we give TPA, if I give tenecteplase, it is going to act much quicker. No, it is this you're giving over 1 hour. Right? Whereas the tenecteplase you're giving as a bolus, what is the dose? The dose is 0.25 milligram per kilogram to 0.45 milligram per kilogram. What has been proven is, those patients who have gone for mechanical thrombectomy, they found that those patients who received tenecteplase had a better clearance as compared to those who had received TPA. What do they find? That those, see, some patients of them now, they went for accelerated thrombolysis mechanically. That means they first got the thrombolysis and then they found they know it's a large vessel, it's a large dense MC, and then so they went for mechanical thrombectomy. So those are those patients in which you can see what is happening, whether how much is gone, how much is remaining, how much is not remaining. Got the point? You're getting the point. So in those patients, what they found, that in those patients which you use tenecteplase, the removal of the clot or clearance of the clot was much higher than that in whom they received TPA. That's why tenecteplase seems to be a drug that will probably come into the future and something that we might use on a regular basis. In fact, today, given a choice, if I have to use TPA versus tenecteplase, in my opinion and the evidence that comes in, tenecteplase would be better in all aspects. Because it is fibrin specific, the half-life kinetics are very good, the fact that it works immediately is good because time is brain after all. And fourth, we have some evidence that documents the fact that it's been more better than TPA when it comes to mechanical thrombectomy patients. You know, we know that evidence. Clear? So it does appear that tenecteplase is probably going to be the way to go in the future. Okay. However, as of now, the drug of choice is altiplase. But today, if you start tenecteplase, nobody is going to tell you to do it because the guidelines say that you may consider tenecteplase. If you look at the guidelines of stroke, the American Heart Association has said that you may consider tenecteplase on a case-by-case basis. It is said in the guidelines. It is there in the guidelines very clearly. It's not there. It is there in the guidelines. Clear? Clear on this? Now the question that comes is, which are the patients in which you will say, okay, don't give this tenecteplase or alteplase. That's why you must understand three different classifications, three different places where you will probably think about it. There's no pen here. This is in short where you will think 100 times before you actually give thrombolysis, isn't it? Now the first question is, I decide to give thrombolysis. I decide that this patient characterizes thrombolysis, means he is within 3 hours of the last seen normal, or he is within 4.5 hours of last seen normal, or he is in the time frame where the diffusion, or is a wake-up stroke where the flare is not showing anything but the diffusion is showing something, which again indicates that this is the indication to give thrombolysis. You understood, no? 3 indications. First indication will be within 3 hours of last seen normal. Okay, 3 hours of last seen normal and the CT scan is completely normal. The second indication is less than 4.5 hours of last seen normal. Okay, again, and I'll tell you why there is a difference in how you should speak to patients before at 3 hours and at 4.5 hours. Right? And the third thing is when the patient has got a diffusion flare mismatch, which basically indicates that the flare is not lighting up but the diffusion is lighting up, again indicating that this is a candidate where you can do thrombolysis. This is for IV thrombolysis. For that matter, when I say IV, there is also intra-arterial, of which the evidence is not very clear, and then comes mechanical thrombectomy. Clear? Clear on this till now? Now my question that comes is, in this category of patients, there will be certain category which I know that this is now within the time window. I have now established my time window. On this aspect. This doesn't mean that if the patient has come at 1 hour, I have 3 hours. It is not like that. If the patient has come at 1 hour, means I have 1 hour, 1 minute. You have to think like that. Are you understanding? You don't say that, okay, I have time till 4.5 hours. It has to be extremely urgent because, as I again say, 1.9 million neurons are going per minute that you are wasting. So the urgency to give the thrombolysis should be as much as when it is at 4 hours and 20 minutes versus if it is at 1 hour. Urgency to give the thrombolysis. Are you understanding this? Urgency. That means I will leave everything that I am doing and I will do only this work to ensure that the drug goes inside the vein. I will leave all my other jobs, whatever I am doing, and I will just work for getting this drug into the vein. That is what I am going to think. Right? So the urgency, it's very important you understand the urgency of this. I can't say give an order and go and start doing my other work and finishing my notes. It is not like that. If I'm doing thrombolysis, I'm standing there, start put this stuff quickly, and then I want the thrombolysis to happen. Right? But there is a category of patients in which I would not do thrombolysis, and that I would divide into 3 parts. One in which there is no indication only. I first got my last seen normal. But now I need the indications, right? So if there is a hemorrhage, subarachnoid hemorrhage, I would not do that. Of course, it's a subarachnoid hemorrhage, there may be something else there. Number 2, if there is intracellular hemorrhage, I can't do it. If there is intracellular, definitely I can't do a thrombolysis, isn't it? I can't do a thrombolysis in these patients. Then which are the other indications? Large stroke, already seen on the CT scan. On the CT scan itself, I am seeing a stroke. The aspect score has changed. You don't have aspect score, right? But you're just looking at the stroke. If there is an evolved stroke in the brain already, there is no point of doing a thrombolysis. It's an evolved stroke. Stroke is formed. It is beyond time. Understanding? Big large stroke is already there. You don't do a thrombolysis in these cases, right? Then the other category of patient is when, and the relative contraindication comes over here is when the blood pressure, as she mentioned, is more than 185 by 110. And why am I calling it relative? Because this is the time that I want to quickly get this patient under control blood pressure. If I have 185 by 110, I am not doing it because there is a chance of conversion. There is a chance of problems that are occurring. Okay. You understand what I am saying? So that is the reason that I want. So what do I do in this case? If it is 185 by 110, what do I do? My urgency to do the stroke thrombolysis is still on. and I want to effect a stroke thrombolysis, and that is the reason I want to get the blood pressure down as quickly as possible. So what would I do? The fastest, quickest drug that I have in my hand, which is the most potent drug here? No, it's not. It's not. It's not. The most potent. What is labetalol?
Beta blocker.
So we don't want a beta blocker here, right? The problem over here is what? The problem over here is the fact that these patients are having extreme alpha blockade. Sympathetic, no overdrive. It's a simple. The patient has had a stroke in the brain. When the patient has had a stroke in the brain, it is not his heart that is having more inotropic. It is the alpha effect that is coming in. Sympathetic overdrive. Understand the pathophysio? Sympathetic overdrive. That means the patient is vasoconstricting so badly that he is unable. So in that stage, if you give a beta blocker, there is a possibility. There is an outside possibility that the cardiac output will fall. Are you understanding? Because it's a negative inotrope. Remember this, labetalol is a beta blocker and not an alpha blocker. Okay. However, it is a titrable agent. If I want to actually get down the BP, the drug of choice would be clopidogrel. We don't have it. Or nicardipine. We don't have it. Okay, clopidogrel, nicardipine. These are two drugs that would be the drug of choice in these cases because there are alpha blockers. You understand? Clear on this? Since we don't have those alpha blockers, that is why we are resorting to beta blockers and trying to take that effect as much as possible. Okay, so my situation is I want to do this quickly. How much time I have? Hardly I have any time. No, as I am waiting, the patient is deteriorating. This is what is going to happen because it's a stroke in evolution, right? So I will do this quickly. So I will give say a bolus of 10 milligram. Wait for exact 5 minutes of labetalol. Exact 5 minutes I'll wait. I'll stand there with the patient. I will check manual blood pressure. I don't know arterial line. Manual blood pressure. I will give 10 milligrams of labetalol. Wait for around 10 minutes. Wait for 5 minutes. 5 minutes. Subsequently, immediately give the next 20 milligram if it's not getting better. If 20 is not working, I'll give the 40 milligram. Not working, go to 80 milligram. And by this time, I've lost how much time? See, 5. That's I lost 1, 2, 3, 4. 1, 2, 3, 4. 20 minutes. So what did I do? This is not the right technique. You are understanding what I'm saying? I've lost 20 minutes of good hard-earned neurons, which is going down. It's not something I want to do. It is something quite sick. Imagine your some relative coming over there and your labetalol देके तुम बाहर घूमने जा रहे हो, तुम दूसरा patient देख रहे हो, तुम time. Imagine what is happening to this patient's neurology. For life, patient is going down. For life, his neurons are going. For life, his cognition is going. For life, his entire functionality is going down. So for you guys, what you need to do, be urgently trying to get the BP down. So what do you do here? I'm not getting this down. Immediately switch to within the first 2 times only, you switch to something. You understand? Switch to maybe an NTG, switch to maybe an SNP, switch to maybe an esmolol. So you want to do this much more quicker. The better option than labetalol could actually be esmolol. Much more quicker. How do you give esmolol? Don't think too much. 25 milligrams stat followed by 3 to 5 milligram per minute. That is the approximate dose. Esmolol. So 25 milligram stat, esmolol, because it works very quickly. It works very quickly. You give 25 milligram stat as a bolus and directly start at 3 to 5 milligram per minute. Don't think only. This is what you need to start. Okay. So as part of the entire story, just start this. Just start this. You can start labetalol, but labetalol 5, 10, 15. Once you reach 20 or 25, you lost 10 minutes, start the NTGs. Don't wait too much. Start the NTG. Because the entire objective is to get this to less than 180. Right? The other place where I would not want to use this relatively is a post-ictal state. Post-seizure. Because you can't identify whether the problem that is occurring to this patient is post-ictal or is it actually the stroke. For example, you have a patient who comes in from outside with a seizure, and then he's come to you. You do a scan, okay, and now he's not moving his left side or is not moving left side like that. You're pinching him, but the left side is not moving properly. All right, the CT does not show or reveal anything. In your mind is 1.9 million neuron, 1.9 million neuron that is coming in your mind, but this one side is not moving properly. Okay, so this is a post-seizure, but this could be post-ictal phase. This should be post-ictal palsy. You understand? So it's very difficult when you have post-seizure. So that comes as one of the relative contraindications to give TPA. A post-ictal state. Clear? Because it might not require the TPA, it might be just a post-ictal state. Clear? Then the other category of patients where you will think is when there is a chance of intracranial bleeding. When there is a chance of intracranial bleeding. This is another category of patients where I will think hard before I thrombolize these patients. And which are these patients? Which are these patients? Can you tell me which of these patients will have a chance of intracranial bleeding?
Previously on anticoagulants.
That will be systemic bleeding.
Aneurysm.
That will be systemic bleeding. You understand? So intracranial.
Aneurysm.
Aneurysm. So if you have an aneurysm that is more than 10 millimeters in size, these patients would be the ones. So which of these patients? Sometimes what does happen is there are patients who have very rarely but this can occur, that these patients have had a headache in the past and some neurologist has actually advised a CT angio, or the neurologist advised MR angio. At that stage they figure out that they've got an aneurysm. So that कोई coil नहीं करने वाला है. If there's an aneurysm, it doesn't mean you need to coil it. It is not like that. If the patient gets an aneurysm, we advise them, don't take alcohol, don't take tobacco, control your blood pressure. We do all these things. We don't tell them go and coil it. Are you understanding? So you will have some category of patients who come into you with an aneurysm, okay, and you already have a background saying fuga hai brain ke andar. You figure out what is the size of the aneurysm. So this is one place where you will probably not do thrombolysis. Which is other place? Any idea?
Brain tumor.
Exactly, a brain tumor. If you have a brain tumor, SOL, these SOLs have a chance of actually having a bleeding inside the brain. Okay, have a chance. So if you have a SOL in the brain, this is one place where you think hard before doing it. And many patients would come this way. They will have an SOL in the brain, I don't know, and they don't know, they have not done anything to it because they're just normal, there's nothing. So you will not probably do anything. There is a glioma, something is there, some small thing is there in the brain. So that is something very not. So if it's a tumor in the brain, this is a tumor in the brain. Next, which other way? Now just like a aneurysm, you will have arteriovenous malformations, AV malformations. So you have AV malformation in the brain. Another place where you think before you thrombolize these patients, AV malformations. You will not probably want to do it. Then you have a disease called as moyamoya disease, large amount of vessels here and there. That place also I'll think about it. An intracranial problem that can occur in this moyamoya disease. Then which condition inside the heart has a high chance of bleeding in the brain?
And endocarditis.
Endocarditis. Bacterial endocarditis. So if you have bacterial endocarditis, these are those patients who can have
Contraindication.
contraindication. So we have come to that where there is back. So what is your take when you're there in the when you're going to contemplating a thrombolysis? You're auscultating. You auscultate, you find a murmur. Be very careful. If there is a fever, be very careful. Okay, that's why the auscultation becomes very important. Bacterial endocarditis is a contraindication to go and thrombolize these patients. Because these patients can embolize into the brain and then they can bleed into the brain. So it's a dangerous thing to do that. So intracranial bleed is something that you might get when you actually thrombolize these patients. Bleed. Then the other bleed that we are worried about is systemic bleeding. Isn't it? Systemic bleeding. So this is intracranial, intraaxial bleeding. Okay. Intraaxial bleeding can also occur when there has been a spinal neoplasm. Intraaxial bleeding. So intracranial SOL, intraaxial spinal neoplasm can also cause intracranial, intraspinal bleeding. The other is systemic bleeding. Now when is systemic bleeding going to occur? Systemic bleeding. It's when the patient is on exactly when the patient is on a warfarin and the INR is more than 1.7. When the patient is on a warfarin and the INR is more than 1.7, not just being on warfarin. You have to be on warfarin and your INR has to be more than 1.7. So that is going to cause systemic systemic bleeding. Systemic bleeding means bleeding anywhere in the GI tract, anywhere in the in the lines, in wherever there is systemic bleeding. So systemic bleeding. Then the patient who's on any novel oral anticoagulant in the last 24 hours. If the patient is on any novel oral anticoagulant, see your incidence of getting novel oral anticoagulants is going to be higher than your warfarins. That means apixaban, rivaroxaban, dabigatran. These are the ones I want to see. Okay, so if the patient is on novel oral anticoagulant that is within 24 hours, this is another place where there is a chance of systemic bleeding anywhere in the body. Then, if the patient has undergone any surgery in the last 14 days, last 21 days में अगर surgery हुआ है और last 14 days में GI bleed अगर हुआ है, if the person has had a GI bleed in the last 14 days, or the patient has had surgery in the last 3 months also, this patient has got a chance of bleeding. Okay, so systemic bleeding. So always remember when you're methodically, you be methodical when you are actually looking at patients, because you don't have time. Wherever you don't have time, now you have to be methodical. If wherever you don't have time, you have to be very methodical. If you're not methodical, now you will miss out. So your history taking is going to be on that level. You are going to look at whether what is the incidence of giving IC bleeds, what is the incidence of getting systemic bleeding, or whether I can't thrombolize. These are the things I'm going to look at. So can't thrombolize, intracranial bleeding, and systemic bleeding. If you think like this, you will probably be able to get your history in the right place. Of course, you're going to look at the checklist also. The checklist also comes in for IC average, but this is how you take a history. Clear? Okay, now you've gone through the whole thing and you now decide, okay, I want to thrombolize this patient. Now, if you want to thrombolize this patient, you need to tell the relatives now. You have done this, so you don't tell the relative in the first go, I'll thrombolize the patient, let me check the checklist if everything is okay. ऐसा नहीं होता है. So the process is, patient comes to you, you have found out that patient has got a stroke. Now, after the patient has had a stroke, you have done the scan. The scan reveals that there is possibility of thrombolysis here, because there is aspects, everything is clear on that. There is no big evolved stroke, there is no stroke seen, actually very tiny thing is there, and it's within last seen normal. You have gone through your entire checklist saying that this is what it is. Then the next step is sitting with the relative. Okay, what do you tell the relative? So let me ask Kadapa, what will you tell a relative? So you have to give TPA, right? What are you going to tell the relative? What are your words?
Patient is within a window period.
Okay.
If you thrombolize the patient, so there is no chances of clearance. And
No, so you have to be very clear, very clear how you're going to talk.
there will,
Go on.
you cannot make sure that complete clearance.
No. So what are you going to say, Niharika? Let me see what you're going to say.
There will be chances of bleeding
Bleeding.
6% if you thrombolize the patient.
So I'll explain to you how you talk this. Okay, how you're going to talk. So if there's a patient sitting in front of you and there is a stroke that is happening and you want to thrombolize, what are you going to tell them? You're going to tell them very simply, see, there is a clot which is causing, there is a small occlusion or there is a blockage in the artery. You have to tell in this language, there is a blockage in the artery that is causing this patient to behave this way, causing a stroke inside the brain. We can do something by giving a medicine like a clot buster, which is called as TPA, or tenecteplase, you are thinking about it, which will help to remove that clot. In the event that you do TPA therapy, out of 100, 32 will have a good outcome and only 3 will have a worse outcome. You got the point? This is what you want to say when the patient is within 3 hours. That's why I said this. So once more I'll tell this. Your patient is undergoing a stroke. Okay. And this stroke is because there is a clot in the artery which is supplying the brain. One of the arteries that is supplying the brain. We have a medicine called as TPA, which is clot busting agent. This will help to remove the clot or dissolve the clot. However, out of 100 patients, 32 will have good outcomes. They will go back to their good functional activities out of 100, and only 3 will have worse outcomes. Okay, this is what you're going to tell them. Okay, now if the patient is not at 3 hours and if the patient is 4.5 hours, then what do you talk? Then you talk something very different. What you will say? Out of 100, 7 will have good outcomes. Out of 100, 7 will have good outcomes and only 3 will have bad outcomes. Okay, so TPA is a clot busting medicine. This particular patient is having a clot inside the brain, inside the vessel, which is causing stroke. It is important we give this clot busting agent quickly. Out of 100, 7 will have good outcomes because you are in the 3 to 4.5 hour window. You are clear on this? And only 3 will have worse outcomes. So these are the specific words that you are supposed to use. The specific words you should use. Clear on this? Clear on this? When you use these words, it becomes very clear to this patient's relative what they are expecting. Okay, clear? Clear. Okay, so when does the outcome improve? How does the outcome improve? The outcome actually improves as per the NIMS RTPA trial at 3 months. Okay, though people mention about the fact that within 6 hours, within 12 hours, patient starts moving extremity and things like that. No, but the overall outcomes and improvement in overall functional ability occurs at 3 months. Okay, there's a 10 to 11% improvement in outcomes at 3 months. Clear? So don't. Today, if you do thrombolysis and you tell and the patient doesn't really improve markedly, you still will tell the patient the improvement is still seen at 3 months. Wait and watch. You got the point? You understand? This you must understand because the NINS RTPA trial looked at absolute improvement in outcomes at 3 months. Clear? These are all practical aspects that you should understand. Clear? At 3 months. Well, what did they ask? What is the problem if you have thrombolysis? What can be the problem side effects? How are you going to monitor the thrombolysis? So, for example, today I started thrombolysis. What is the next thing I tell the nurse?
BP monitoring. BP monitoring.
So, anyways, you're doing it.
Every 15 minutes.
You have heard this lecture with the nurses. Yeah. So, you are supposed to tell the nurses. What are you going to tell the nurses?
Neurological monitoring, BP, sugar.
BP monitoring is number one first.
Sugar.
So, in the BP.
Sugar.
So, what is BP monitoring?
BP.
First 5 minutes,
What's first 5 minutes?
15,
For
every
15
15 minutes
minutes.
for 2 hours, every 15 minutes for next 6 hours, and then 1 hourly for
Correct. So you are going to write this on paper. Every 15 minutes for the first 2 hours. Every 15 minutes for the first 2 hours. Every 30 minutes for the next 6 hours. And every hour for the next 24 hours. This is what you're supposed to write on paper. Okay. Every 15 minutes for the first 2 hours. Every 30 minutes for the next 6 hours. And every hour for the next 24 hours. This is what you're supposed to write on paper. So that these nurses follow what we're telling them to do. And in this scene, what can cause neuro worsening? So what can cause neuro worsening? So for example, and you're going to obviously tell them, look at the neurology, chart the NIHSS score and look at neuro worsening. NIHSS score worsened by more than 2 indicates that there is neuro worsening. But what could be the reasons for neuro worsening?
Hemorrhagic transformation.
Sorry?
Hemorrhagic transformation.
So what is hemorrhagic transformation? Before you go to hemorrhagic transformation, what other reasons could be cause of worsening?
Inadequate thrombolysis.
So many things. Seizure. There could be a seizure that comes in. There could be a seizure that comes in which causes neurological worsening. You got the point? There could be a sudden electrolyte abnormality that is occurring in these cases causing neurological worsening. There could be aspiration that causes neurological worsening. There could be hypoglycemia that is causing neurological worsening. A fever could cause neurological worsening. There are so many things that you rule out, and there could be cerebral edema that could cause neurological worsening. However, now let's take cerebral edema and hemorrhagic transformation in and understand which of the patients will have neurological worsening from edema and which of the patients will have neurological worsening from hemorrhagic transformation. Clear? So, which are those patients that will have edema? So, if you have a patient who have thrombolized and the patient has got edema, what does that mean? What does that mean? That means to say this is dense MCA. You understand? So ideally, within the last seen normal, if it is within 3 to 4.5 hours, there is no chance of forming edema. So, बहुत जल्दी है ना? It's too early. 3 to 4.5 hours में there is no stroke also formed. But in 3 to 4, that is why in 3 to 4.5 hours, if you find edema inside the brain in your CT scan, it means to say this is an indication of a dense MCA stroke, something that you don't have to thrombolize. Okay, the corollary to that is if you have a stroke with a dense MCA and within 6 hours you see edema, within 6 hours you have edema, this patient can worsen quickly. That's a dense MCA. I'll explain this to you once more. Okay, so every patient of stroke will not go into an edema, which will be catastrophic. And if the edema has to develop, it will take more than 6 hours for it to develop. The edema will be seen at 24 hours, up to 24 hours. You understand? At 24 hours ke baad, you start manifesting edema. At 3rd or 4th day, the edema will be maximum, and then it will start coming down. Right? And there are 2 kinds of edema. What are the 2 kinds of edema? Cytotoxic edema and vasogenic edema. What do you think is the difference between both of them? Go on.
Cytogenic edema is due to the release
Cytotoxic.
of cytotoxic is due to the release of toxins of WBC.
Inflammatory markers.
What is the difference in pathophysiology? What is the difference in treatment?
Treatment method, steroid is helpful in cytotoxic.
It's the other way around. So it's the other way around. So cytotoxic and vasogenic edema. There are two things. Okay, cytotoxic and vasogenic. Now cytotoxic edema occurs because cells are dying. Cells have died. And how the cells have died? Because there's a stroke, there is something inside the brain, there's a trauma or something that has occurred which has caused the cells to swell. Cells, that's why it's edema. Cytotoxic edema. Cells are swelling, calcium is getting into the cell. You know, calcium, electrolyte imbalances are occurring, cells are swelling up. And that's why it is called as cytotoxic edema. Okay, since cells are swelling up, nothing is going to work in these cases, right? Whereas when you have vasogenic edema, it is a problem of the blood-brain barrier. The blood-brain barrier is getting disrupted because of which there is edema inside the brain. So, if you get the blood-brain barrier to stabilize, the edema will reduce. That's why the steroid. Notice that blood-brain barrier is inflamed. You give steroid, it reduces the inflammation, and thus it causes reduction in vasogenic edema. So, vasogenic edema will come in, say, hypertensive bleed around the area. Cytotoxic edema will occur in ischemic strokes. That's why in ischemic strokes, there is really no role of giving a steroid. Okay, there is no role of giving a steroid because it is cytotoxic edema. Clear on this? So you can develop edema. So this means to say, to cause cytotoxicity and then cause edema, it has to be really old or really big. This means to say, if a stroke needs to cause cytotoxic edema, the stroke has to be either very big or very late. Unlike brain, unlike vasogenic में क्या होगा? Trauma हो गया, ढक करके vasogenic edema develop हो गया, blood brain barrier disrupt हो गया. You understand? So edema is there on day one. That means these patients who come with traumatic brain injury, edema will be there on day one. You understand? But when you have cytotoxic edema, it is going to take time, no, for the cell to first swell, after that become edematous. It's going to take time. So if it is occurring very quickly, means this is a very large stroke, which is basically indicative of an MCA syndrome. MCA syndrome. So MCA syndrome are those in which the stroke is so big, okay, that this patient may require decompression. You understand? Decompression. This is that stroke that will go through extreme cerebral edema. Decompression. May require decompression. Hi. Just a minute. So that MCA syndrome is when you have dense MCA, very large strokes. When I say very large strokes, last time I explained to you what is MCA syndrome. What is very large?
More than 50%.
More than 50% of the MCA territory, or
more than 8 mm length of length is involved.
More than 8 millimeters. So one is more than 50% of the MCA territory, even some even more than 30%. Okay, more than 50% definitely, more than 30% sometimes. Okay, then
and the M1 segment.
so more 8 millimeters occlusion of the MCA. Then
M1.
Then I explained to you last time. You have more than 2 territories involved. ACA and MCA involved. MCA and PCA involved. Okay, that's also called as dense MCA. Or you have within 6 hours your CT scan is showing edema, or your MRI shows more than 84 ml of diffusion. 84. So I explained to this last time. 5 signs that will tell you that this is very large stroke. Which are the 5 signs? You have more than 8 millimeter size MCA occlusion. Second one is more than 50% of the MCA territory is involved. 3. MCA plus PCA or MCA plus PCA ACA territory involved. 4th, you have stroke sign, that is CT less than 6 hours but there is edema. And 5th, the patient has got an MRI that shows a diffusion volume of more than 82 ml. Okay, so these are all indicative saying that this possibly is a MCA stroke, or this is a MCA syndrome. These are those patients that if you thrombolyze, you'll have a very high chance of hemorrhagic conversion. A very high chance of hemorrhagic conversion. These are those patients that may require an accelerated decompression craniotomy. These are those patients that will require an accelerated decompression craniotomy. So now you can understand that which of those patients who will require an accelerated decompression craniotomy. Okay, these are those patients who will require them. Classically, these are those patients who are younger in age. Why younger in age? Because of the fact that when you are young, your brain is less atrophic. Since it's less atrophic, there is less space for it to expand. Since there is less space for it to expand, your brain gets squished. You understand? And that causes raised ICP. Remember this, this is never global ICP elevation. ऐसा होने नहीं वाला इसमें एक territory involved है. Global ICP involvement, that means the whole brain gets edematous only when you have a trauma. Are you understanding? Or you have a hypoxic arrest. when you're doing CPR and all, that might cause global ICP to elevate. Here what is going to happen, one side of the ICP is going to increase. So the indications for decompressive craniotomy should be on your back of your mind when you're doing this, because the repeat CT will show midline shift. Clear? The repeat CT may show midline shift. Clear on this? Okay, so the other thing that happens is, as you rightly said, now you understood edema, right? Now the other thing that comes to your mind is hemorrhagic transformation. This is what is coming to your mind, right? So what is the meaning of hemorrhagic transformation? So I last time explained to you, hemorrhagic stroke will involve cerebral venous sinus thrombosis with stroke. When in an IC bleed, when a stroke is getting converted to hemorrhage, these are all called as hemorrhagic stroke. So don't confuse yourself. Hemorrhagic stroke means there is going to be infarct conversion to hemorrhage, or cerebral venous sinus thrombosis causing hemorrhage. Whereas IC hemorrhage is completely different, where the patient has got a bleeding into the brain, primary bleeding into the brain. Clear on this? It's very different from hemorrhagic stroke. Don't confuse those two terms. IC hemorrhage is different, hemorrhagic stroke is different. Hemorrhagic stroke may involve everything. IC hemorrhage is only that. Clear? So hemorrhagic stroke can also be IC hemorrhage. You got the points? But IC hemorrhage is IC hemorrhage. Clear? So when you say hemorrhagic stroke, what you should understand is there are 3-4 types of hemorrhagic strokes. Okay. So one is called as, it may be petechial hemorrhage. Okay, H1 this is called. H1, petechial hemorrhage, means there is small petechial hemorrhages around the stroke. Small petechial hemorrhages around the stroke is called as H1. Okay, PH1, some people call it PH1. Then when there is petechial hemorrhage inside the stroke, many territories inside the stroke, it is PH2. This is PH2. It's classified that way. Okay, petechial hemorrhage 2 is classified as 2. Right? So petechial hemorrhage, so small dots of bleed around the stroke is petechial hemorrhage 1. If there is multiple areas that are involved, it is petechial hemorrhage 2. Okay. Next is hemorrhagic transformation 1, HT1, which basically means less than 30% of the area is involved with the bleeding. Less than 30% is involved with the bleeding. Less than 30% of the stroke area is involved with the bleeding. It's called HT1. Okay. And HT2 is more than 30% of the stroke is involved with bleeding. Clear on this? HT1, HT2. Clear on this? So petechial hemorrhage 1, what is H1? When there is small hematomas, small areas of small bleeding around the around the stroke area. HT2 is when there are hemorrhages inside the small hemorrhages inside the bleeding, inside the stroke area. H1 is when less than 30% of the entire stroke area is involved with a bleed inside, and when more than 30% is involved, is called as HT2. Clear on this? Clear? Clear on this? Petechial hemorrhage, hemorrhage and hemorrhagic transformation. This is called as hemorrhagic transformation. There are 3 kinds of hemorrhagic transformation that might occur. One would be called as asymptomatic hemorrhagic transformation. Why would that occur? Say you have a stroke already evolved, a big stroke that is there. उसके अंदर अगर ये होगा, it will not be related to symptoms. Symptoms will not come because that's a dead brain. You want to say it's a dead brain? There's space in that place. That's where the hemorrhage is occurring. That is asymptomatic hematoma. Clear? The other are microbleeds. Microbleeds again will not cause too much of problems. And the large one is large hemorrhagic transformation, and this is what we're talking about here. Hemorrhagic transformations. Symptomatic hemorrhagic transformations. Clear? So what we've understood as of now, what to do, how do you find out how to talk to the patient about thrombolysis, which are the drugs that we have in thrombolysis. When you are going to talk to the relatives, what do you tell them about thrombolysis? How do you perform thrombolysis? Which patients you don't perform thrombolysis? And what happens after thrombolysis with respect to monitoring and with respect to what is the side effects of thrombolysis? Okay, we also have a side effect of thrombolysis called angioedema, a completely different thing, radical-induced angioedema. Let's not even get into that. Okay, edema. And the final thing that you have to think is what do you do if you have this neurological worsening? So if you have a patient who is there and your NIHS score has dropped by 2, what will you do? Atul, what will you do at this stage?
Repeat CT. But first we have to rule
Correct. So obviously you will do the usual BP, pulse and all those things. You will do the vital sugar, all that you will do. Stroke mimics you will rule out. But the first thing you should quickly do is a CT of the brain. Very essential. Very essential. The CT brain is so essential. Why? What do you want to look at?
either emergency.
This is what I want to look at.
cerebral
This is what I want to look at. Cerebral edema is what I want to look at. You understand? There are two things I want to look at here. Cerebral edema and hemorrhagic transformation. Only two things I want to look at. I am not concerned with anything else. Okay. Cerebral edema अगर आ गया, so obviously I need to start thinking, call the neurosurgeon, try to decide what should be done because it's too early. Okay. And if there is hemorrhagic transformation, then
we have to stop we have already stopped the antiplatelet infusion.
so hemorrhagic transformation अगर हुआ, okay, hemorrhagic transformation अगर हुआ, then our entire thing is to reverse the thrombolysis. Is to reverse the thrombolysis. You understand? The entire thing is to reverse the thrombolysis once you have hemorrhagic transformation. You understand? It's very essential because remember this: if a person is getting a TPA with a stroke without a this also there is a 2% chance of hemorrhagic transformation. ऐसा नहीं कि तुम्हारी thrombolysis की वजह से हो रहा है. Remember this, that a person who has got a stroke in the brain has got a chance of spontaneous hemorrhagic transformation in 2% of indications. And when you do a thrombolytic, there is a chance of around 6%. Okay, if you look at it on a case by case basis, 3 times the amount of normal it is, 2% to 6%. Okay, 3 times the amount of normal. Clear? That is the indication this of getting a hemorrhagic transformation. Clear on this? 2% to 6%. Very important. Clear? So what do you do in these cases? I would immediately ensure that I control the blood pressure in a very good way. It's very controversial what should be the blood pressure target in such cases. Okay, but on an average it should be between 140 to 160. We will follow the IC hemorrhage guidelines. It should be not less than 130. It will be somewhere around 140 to 150. So tight control of blood pressure. You will send investigations: stat, CBC, BUN, creatinine, electrolytes, fibrinogen. These are the things that you will send in an urgency because this is a fibrinolytic medicine. Since it's a fibrinolytic medicine, we are expecting the fibrinogen to go down. This is not the scene when it comes to tenecteplase. It doesn't cause so much of fibrinogen coming down. Okay, the alteplase will cause more amount of fibrinogen to come down. That's how it is. Clear? So what do you do in this case? Once you do this, what is the next step that you will do in this case? After this, what will you want to give?
FFP or plasma corresponding.
No.
Cryo.
Cryo. The answer is cryo. FFP is not the answer at all. The FFP is not the answer at all because of the fact that what is going here? Fibrinogen. What are you going to give by giving FFP? No, it's not something I want to do. I will be giving 10 units of cryoprecipitate stat. 10 units of cryoprecipitate stat, the effect of which comes within 30 minutes. So it has to be given over 10 minutes. So cryoprecipitate is not give 10 cryoprecipitate. It is ask the cryoprecipitate and push that cryoprecipitate in. It has to go within 10 to 30 minutes. So I would not say 30 minutes also, I would say 10 minutes. Let it go in as quickly as possible. So over 10 minutes. So take it, aspirate, give it, push it inside. Then let those 10 cryos go inside and an hour later, maybe not hour, 30 minutes later, if you are doing it within 30 minutes, repeat the fibrinogen. If the fibrinogen is more than 150, is less than 150, again give the cryoprecipitate. You got the point. Again give the cryoprecipitate. So I give 10 units of cryo, look at the fibrinogen. If it is less than 150, give another 10 units of cryo. This is how it works. Clear? This is how it works. Understood this? So this has to be done in urgency. You may want to add a tranexamic acid which can be given because that is an antifibrinolytic agent, right? It is an antifibrinolytic agent, so I can give tranexamic acid. How will I give tranexamic acid?
1 gram over 10 minutes.
1 gram stat. 1 gram stat. No 10 minutes. 1 gram stat. And follow it by 1 gram over 8 hours. Okay, 1 gram over 8. So 1 gram stat and 1 gram over 8 hours. This is the protocol that we use for tranexamic acid. Clear? So this would basically reverse your thrombolysis. This is the entire thinking. Do you reverse your platelets, antiplatelets? You have not given antiplatelets till now, so it's out of question. Because your antiplatelets are given after 24 hours. Clear? Antiplatelets are given after 24 hours. Clear on this? Any questions on thrombolysis now? Now that you've understood this entire thing? Let's stop this now.